talking is important, and we want to make sure that we're all speaking the same language when we talk about disc pathology. Why is it so important? I actually was giving a talk a couple of months ago, and after the talk, somebody came up to me and said that a very prominent neuroradiologist in this country was aware of this nomenclature and essentially abandoned it and doesn't use it because their local surgeons don't buy into it, essentially. And she says, and of course, it's important that when one's communicating, especially dictating a report, that everybody be on board. We as radiologists can't use terminology that you as surgeons aren't using in your daily practice. So that's one reason why it's important. But even more so, I think we're entering an era now where the electronic health records are ubiquitous, and there's going to be a push, there is a push to adopt the learning healthcare system, to use this massive amount of information that we have to better understand disease processes. And so this is an opportunity for us, using standardized nomenclature, to interrogate these massive amounts of information that are out there so that we can better learn about these processes that, frankly, we don't have a great handle on at this point. And so as we enter the era of large pragmatic trials, which we are entering, standardizing how we report things is going to become critical. So this consensus nomenclature that I'm going to be talking about, probably which most of you are familiar with, has been around now for over a decade. And pretty much all of the major societies that deal with spine have signed on to this nomenclature. So there's relatively little controversy, I think, left about what we should use. The goals of the nomenclature are that it be practical and simple to use, and that most importantly, that there be a high inter-observer agreement. Because if you have a classification system that people can't agree upon, then it's pretty much worthless. In a nutshell, what the nomenclature does is it looks, and this is just referring to the disc itself, you can classify a disc as either being normal, degenerated, and there are all sorts of subcategories of degeneration. It may have an annular fissure, also known in some circles as an annular tear, and then herniation, of which there's subclassifications, which I'll get into in a second. So normal disc. Normal disc is well hydrated. It may or may not have this central dark band, which has also been termed a central band of fibrosis, which is probably on the MR, and I'll show an example of it shortly, just a higher concentration of these central proteoglycans. So you get signal loss on the T2 weighted images because of this higher protein content. Note that age-related changes in this nomenclature are not normal, so we're expected to describe them. That doesn't necessarily mean that age-related changes are related to pain. It's simply that they're distinguished from a normal-appearing disc. Here's an example. It's a sagittal T2 weighted MR of what would be termed normal discs. You can see this dark central line, which is this intranuclear cleft or central band of fibrosis. And by the way, the series of studies that I'm going to be showing are all from a study that we did quite a number of years ago now of patients who did not have low back pain. So these were rigorously screened patients, but we screened them so that they at least did not have current back pain. They may have had back pain in the past, because if you're looking for patients that have never had back pain, you won't find them. But based on pain scales, based on function scales, all these patients were back pain free currently. Another example, nice, relatively young looking spine, well hydrated disc, the heights are maintained. Again, at several of these discs, you see this central dark band, which is normal. So degenerated discs. Degenerated discs may have desiccation or signal loss, which is best seen on either a T2 or STIR weighted image, T2 weighted image with fat suppression. Disc space narrowing, so you can have height loss of the disc. Bulging is included in this rubric of degeneration. and then end plate changes, which have been talked about earlier today. There is some interesting information coming out about end plate changes, also known as modic changes. There are types 1, 2, and 3. Type 1 being essentially end plate edema with presumably hypervascular changes associated with it. Type 2 being fatty changes of the end plate, and then type 3 sclerosis. And then osteophytes are a hallmark of degeneration. So desiccation, again, asymptomatic patient. You can see at L4-5 and L5-S1, there's signal loss. At L4-5, there's a little bit of height loss, a little bit of retrolisthesis at this level. But the hallmarks of disc degeneration, again, desiccation or signal loss, and disc space narrowing. Annular tears, another aspect of degenerative disc changes. Note that the nomenclature actually changed a couple of years ago, and they got rid of the term tear because the connotation was that people might interpret it as a traumatic etiology, and so the preferred term now is an annular fissure, less emotion-laden. A high-intensity zone essentially means the same thing. That's an older term and is not part of the standardized nomenclature. So annular fissure is where we want to be describing these things. It's defined localized disruption of the annulus without displacement of disc material beyond the interspace. Because if you have disc material displacement, you then either have a disc protrusion or an extrusion. Annular fissures, well seen on T2 weighted images. So on the left here, we have a T2 weighted image with fat suppression, and you can see the annular fissures at multiple levels. Note that there are actually different types of annular fissures. People have had subclassified them into radial or concentric or transverse. That's the reliability of that is not great on MR, and probably the clinical importance of that is not demonstrated yet. So that's not part of the standardized nomenclature, that subclassification, but does exist. On the right is a T1 weighted image with fat suppression. These annular fissures enhance. They enhance probably because there's granulation tissue associated with them, and you actually increase your sensitivity for detecting annular fissures if you give contrast. We don't routinely give contrast in people that have not been operated on because, again, the importance of simply detecting the presence of an annular fissure is, I would say, uncertain at this point. But know that we're quite sensitive and we can detect them frequently. Another example of an annular fissure that you can see in a degenerated disc. So herniation. Disc herniations, as part of the nomenclature, have been subdivided into disc protrusions and disc extrusions. And by way of definition, herniation is a localized displacement of disc material as opposed to a disc bulge, which is a diffuse displacement of disc material. And by definition, if more than half the disc is involved, that's a bulge. If less than half is involved, it's a herniation and defined as localized. And just sort of schematically what this looks like, normal disc contained within the bony end plate, a disc bulge, again, diffuse abnormality. A protrusion is a focal abnormality, and an extrusion is a focal abnormality with a neck associated with it. The actual definition of the extrusion is that the largest diameter of the disc material is not adjacent to the parent disc. And that can be true either on a sagittal or an axial image. Doesn't really matter. So just some examples on MR. Bulge, again, diffuse abnormality of the disc. Small central protrusion, which you can see is associated with an annular fissure. Again, this is a T2 weighted image. And the annular fissure, this linear lucency. Is this? Here we go. There you can see the annular fissure there and the small focal protrusion. Another example of a small central focal protrusion. Disc extrusion, again, the largest diameter is not adjacent to the parent disc. So you often see these well in the sagittal images. Largest diameter here of this extruded fragment, and the neck that you can see associated with that. You're all familiar with, there are myriad examples of extrusions. If the extruded disc material is no longer connected to the parent disc. Then you have a sequestered fragment, and those, of course, can migrate. And examine a very large disc extrusion. So, as I said before, any classification system is worthless if the reliability is not good. There have been a number of studies out there looking at the reliability of this protrusion, extrusion classification. And when you have a classification system, a standard way of measuring reliability is something called the kappa, which is a way of taking into account agreement by chance. One aims for kappas sort of in the 0.6 or above range, and the inter-reader reliability is sort of close to that. It's reasonably good. Certainly not perfect, but reasonably good. So that's the disc. There's also a standardized classification system for the neural elements and what happens to them. And this was a scheme suggested by a Swiss radiologist, Firman, who classified nerve root involvement as either the nerve is contacted, displaced, or compressed. And just schematically, again, here's the exiting nerve root, here's the exiting nerve root, here you have some disc material. So the nerve root is not involved in this example. If it's contacted, and another example, focal protrusion, annular fissure, contacted nerve root sitting in the subarticular zone. Then the next level of severity is if the nerve root is actually displaced or pushed by the disc material, and then finally compressed and flattened. And essentially, if you can't see the nerve root adjacent to the adjacent disc material, then it's compressed. And a number of examples of what compressed nerve roots can look like. Left-sided, in this, again, a subarticular zone. You don't see any nerve root sitting there where it should be. You can see the contralateral side, nicely surrounded by CSF, compressed nerve root. What's the reliability of this system, I hear you cry? The intra-reader reliability is quite good, actually. The intra-reader as well as the inter-reader reliability. And so this is a classification system that's reasonable to use clinically. So the fundamental problem that we all deal with, and as a neuroradiologist I deal with on a daily basis, is that whenever you image someone's spine who's over the age of, and pick an age, 35, 40, you'll find something. So there are many findings that one can see, and many of these findings have a poor association with pain. Going back through the ages into ancient times when only myelography was available, people did these sorts of studies. So looking at imaging findings in people that do not have low back pain. So back in the 60s, Hitzelberger did a study with myelography. In the 80s, there were studies with CT. And then since the 90s, a number of authors have looked at MR and the association of various findings with back pain. And this gets to the reason, the rationale for making that distinction between a protrusion and an extrusion. So if you look at any herniation, the prevalence is, and these are actually age-related changes as well, but in these studies, about a quarter to a third of patients had disc herniations. And then Jensen, and this was a New England Journal article that was published in 1994, where they really first codified this use of protrusion and extrusion, showed that while protrusions were quite common, extrusions were unusual in patients without low back pain. And then a number of other studies have replicated that since then. And so hence, the implication is that extrusions are the clinically more relevant imaging finding than protrusion. And then we did this study, again, that I referred to, of looking at VA patients without low back pain, 148 consecutively identified. And if we looked at the baseline prevalence of various imaging findings, we found that nearly 2/3 of our patients had disc bulges, that about a third had disc protrusions, but a very small percentage actually had disc extrusions, so around 5%. Again, concordant with what was out there in the literature. How about annular fissures, which we've talked about? We realized that we're quite sensitive with MR at identifying discography is another way of identifying annular fissures. These are quite common also in people without low back pain. Depending on what series that you look at, around a quarter to a third to even more of patients without low back pain have annular fissures. Gene Karagi did a study looking at, which also looked at annular fissures, and basically his conclusion was that these fissures did not reliably indicate the presence of symptomatic internal disc disruption. Again, because the prevalence is too high without pain attributable to that disc for meaningful clinical use. In his study at discography, the same proportion of patients who were asymptomatic and those who had symptomatic discs with an annular fissure were painful. So hard to draw firm conclusions about the role that annular fissures play in back pain and discogenic back pain. Disc degeneration, again, 3 examples from our study of varying numbers of levels that are involved with disc degeneration. Again, all of these patients did not have low back pain. Prevalence of disc degeneration in patients without low back pain, depending on what series you look at and depending on the age group of that series, ranged from 50% all the way up to nearly 100% in one study. I wanted to touch briefly on some recommendations that came out quite a number of years ago. This was published in The Lancet by 2 quite prominent back pain researchers, Martin Rowland and Moritz Van Tolder. Really, it was a plea, it was sort of a plea for common sense. It was a plea for radiologists to change the way that we report findings. Now, they were talking about plain radiography, but this also applies, I think, to really any imaging of the lumbar spine. And what they suggested was that one put into context the imaging findings by inserting into a standardized report this sort of verbiage. So at the end of the report, one states that 80 to 100% of people without back pain may have this finding, and so the finding may not be related to the patient's pain. We actually adopted this at Harborview quite a number of years ago. And we adopted a little bit, and we simply said was that the following findings are so common, and then we list the findings that they may not be related to somebody's back pain, and incorporated that into the routine imaging report. And then actually just let it get out there and see what happened, see what the result was. We did a retrospective study looking at what happened to the patients that did and did not have this disclaimer that was inserted into the imaging report, because not everybody was using it. It wasn't a mandatory part of the macro that we were using. And we actually were somewhat surprised. We hypothesized that people that had this disclaimer in their report might have less subsequent imaging because people both, and this was aimed at primarily the primary care physicians who we were looking at, that they may be reassured that some of the findings that they were seeing might not be catastrophic, that they might be able to better reassure their patients as to what was going on, and then it would be a tool to help them explain a little bit better about the potential relevance of imaging findings. What we found, somewhat to our surprise, was that there was a decrease in subsequent imaging. There was a fairly marked difference in the rate of narcotic use within a year's follow-up time. Now, Granted, this is a retrospective study. There are lots of caveats, but it was intriguing enough that we decided to go and look at this prospectively. And that's what we're going to be doing over the next few years. We just got funded to do a large pragmatic trial to look at this sort of thing. So in summary, just to wrap up, one can look at imaging findings, those related to aging, those related to prior back pain, those that are common, and just to focus on the last three, clinically, the ones that are likely most relevant are the ones that are related to back pain, not related to aging, and not terribly common. And so if one focuses on extrusions, root compression, and stenosis, we're probably doing well. So the take-home points are many findings were common in people without low back pain, that three findings to be more likely clinically important are going to be extrusions, central stenosis, and root compression. And the plea for common sense is let's all agree to use common terms. Thanks very much for your attention.
Clearly, there's a lot of controversy surrounding discogenic pain. I've put 3 questions on this slide, which I think kind of go right at the heart of the controversy. Number 1, do you believe discogenic pain exists? I would say that we probably don't have unanimity in answering that question amongst all spine providers. Number 2, do you believe surgery has a role for discogenic pain? And certainly that's a little more controversial. And the third is, do you believe discogram is a useful tool to identify discogenic pain? Now, we're not going to cover all this in the next 15 minutes, but for the purposes of this lecture, let's say that discogenic pain exists, just for the purpose of this presentation. For the purpose of this presentation, let's say that surgery is a reasonable treatment for discogenic pain. What we're going to focus on here is, do you believe that discogram is a useful tool to identify discogenic pain? So discography, is the ongoing controversy resolved? For the purposes of generating some hopefully interesting discussion afterwards, I'm going to give a slightly exaggerated presentation here, and I'm going to be a little more forceful in my answer. The answer is yes. In 2012, there is no role for discogram. This is a study that is antiquated and obsolete. It is not specific, it is not predictive, it's not useful in diagnosing the etiology of pain. Not only is it not useful, it is actually actively detrimental to the health of the patient. We've seen it, and I'll discuss why shortly. So what is a discogram? Well, a discogram is a study when the patient is awake and a needle is inserted into the disc, into 2 discs. We insert a disc into the suspected pain generator, as you can see in this bottom disc here, and also into a normal control. And fluid is injected at variable pressures, low pressures and high pressures, and basically we ask the patient, does this hurt? We evaluate the discogram radiographically, but we ask the patient, does this hurt? Does this cause you pain? Does this big needle I'm jamming into your spinal column hurt? And a positive discogram would be if they had pain with injection at the deranged level or the abnormal level, and a negative, and with no pain at the control level. So a negative pain response at the control level, a positive pain response at the suspected pain generator, and then we call it discogenic pain. And if someone does have discogenic pain, there's all sorts of treatments. The surgical treatments we're not going to go into here are largely lumbar disc replacement and lumbar fusion. The difficulty with this diagnostic study is that it's largely dependent on patient-reported pain. You just heard Dr. Jarvik talk about how commonly we see abnormal imaging in patients without symptoms. So this is really largely dependent on patient-reported pain. And I'll submit to you that all pain is somewhat subjective. So how useful is a discogram? So advocates for discogram will point to this study. 1990, JBJS, Walsh and Jim Weinstein looked at 17 patients, and they did a discogram for all these patients. Some of them had low back pain, some of them had no back pain. And they found that there was a false positive rate of 0. But again, their criteria for determining what was a positive discogram was pain with an injection and an abnormal appearing disc on the radiographs. Since then, there's been a lot of studies looking at discogenic pain. A lot of it's coming out of Stanford by Eugene Karagi. This is a study in Spine 2000, provocative discography in patients after limited lumbar discectomy. These are patients who all are status post-lumbar microdiscectomy. Some of them had back pain, some of them didn't have back pain, but they did a discogram on all of them. And there are 20 patients with back pain, 27 patients that are asymptomatic. Again, all the patients underwent discogram, and what they found is that in the back pain population, the discogram was positive 63% of the time. But more interestingly, in the asymptomatic population, discogram was positive 40% of the time. So this is clearly not a specific modality. I mean, we're getting a 40% positive rate in people without any symptoms at all. So at the time of a discogram, this is clearly not a specific study. You might say, okay, well, maybe it's not specific at the time you do the discogram, but maybe it's predictive in people who will get bad back pain in the future, people who will develop back pain. So they took another 50 patients, all asymptomatic, all of them underwent discography, and they followed them out for 4 years. And they found that a painful disc injection in this asymptomatic population did not predict for the onset of low back pain, at least within the 4-year follow-up period. So it appears from Stanford that this study, or this diagnostic study, is not specific at the time of administration, nor is it predictive in figuring out who's going to get back pain. And finally, looking at fusion as an outcome, this is a study in 2006, a gold standard evaluation of the discogenic pain diagnosis as determined by provocative discography. They looked at 2 fusion patient populations, those who are fused for spondylolisthesis, which is essentially universally agreed upon indication for fusion, and those who are fused for discogenic pain as diagnosed by a positive discogram. And one thing I like about this study is they don't present one outcome, they present a whole spectrum of outcomes, meaning they have their highly effective outcomes, which are strict criteria, ODI scores of a certain amount, VAS scores of a certain amount, and they have their minimally clinically acceptable outcome. And these are things like VAS of 1 to 2 points improvement, ODI 15 points improvement, just really the bare minimum of improvement. And what they found is that when they used their highly effective criteria, spondylolisthesis was successful in 72% of those patients, whereas fusion in the discogenic pain population was acceptable or was a highly effective only 27%. And then when they kind of went more lenient on their outcomes, they found that at best discogenic pain fusion was successful in 43% of that population, where fusion for the spondylolisthesis group was as high as 91%. And no matter how you twist the data, how you statistically manipulate the data, they found that the best case positive predictive value for fusion for discogenic pain population is about 50 to 60%. You might as well flip a coin. So those are reasons why discogram may not be useful in helping us diagnose discogenic pain or helping us deal with discogenic pain, at least from a surgical standpoint. But is discogram bad? Is it actually harmful to the patient? And I would submit to you that yes, it is. You've heard Dr. Kang allude to the needle puncture and the effect of a needle puncture on the disc. Howard Ahn, Koichi Masuda, as well as Dr. Kang have studied intervertebral disc degeneration. And in an animal model, there are different ways of inducing degenerative disc disease. There are different ways of studying degenerative disc disease. And one of those models is a needle annulotomy, meaning we stick a needle into the disc, take it out, wait a couple weeks, and boom, we've got degenerative disc disease, which now you can study in a lab setting. If you think back to the discogram, we're not just injecting that bad disc down at the bottom. You have to have a negative control. You have to inject a healthy, controlled disc. You have to purposely stick a needle into an otherwise healthy disc to do your discogram study. And the question we're asking is, does that cause degenerative changes down in the future? In an animal lab setting, we would say yes, absolutely. This is how we study degenerative disc disease in the animal lab model. But there's also clinical evidence to support this. This is a study by Ahmed Nasser and Dr. Kang out of Pittsburgh. Does incorrect level needle localization during anterior cervical discectomy and fusion lead to accelerated disc degeneration? So for the benefit of non-surgeons in the room, this is an intraoperative x-ray of the neck. And what you see here is you see a needle going right into the C4-5 disc space. This is how we identify our levels. We take an x-ray so we know we're at the correct level so we don't operate on the incorrect level. That's fine. So you got a needle at C4-5, but this patient had surgery at C5-6. This patient had an ACDF at C5-6. So now they have a fusion or an arthrodesis at C5-6 and a little needle puncture at C4-5. And they asked the question, what is the fate of this disc where they inserted a needle to localize their levels? And what they found out is that there's a 3-fold increase in degenerative changes in the incorrectly marked level just by that needle annulotomy alone. There's more evidence. This is, again, from Stanford in 2009. This is a 10-year matched cohort study. So this is a matched cohort study. Does discography cause accelerated progression of degenerative changes in the lumbar disc? 50 patients who underwent discography, 52 matched controls. And they followed them out for 10 years just to look at the health of those discs. And what they found out was that in the discography population, there's a significantly higher rate of degenerative findings on an MRI. Now, these are MRI findings, mind you. But they found on an MRI, there's also a significantly higher rate of new herniation in those who underwent discography. And this is disproportionate to the side where the needle was inserted for the discogram. Significantly higher rate of decreased height in the discogram population. Significantly decreased signal in the discogram population as compared to matched controls. So if you believe that degenerative disc disease, at least as seen on an MRI, is a bad thing, discogram may not be the best study to do. It may actually induce degenerative disc disease, may actually induce the disease process that we're trying to prevent or trying to treat. So in summary, is discogram good? Well, I think there's studies out there which question its specificity with a lot of false positives. Is it predictive in developing back pain? Studies suggest that that may not be the case. And predictive of improvement with fusion, well, that's kind of a tougher question to answer because that kind of goes to the question of if fusion is an effective treatment for discogenic pain. We do have some good evidence that discogram may actively be harmful or detrimental to the spine health of that patient. By injection of that control disc, are we accelerating degenerative disc changes? Are we inducing our own progeria in patients who may not have had this otherwise? As I come back to this slide, this diagnostic modality of discogram is really subjective and it's really reliant on the patient's pain response. And all of us know that pain can be adversely impacted by a number of things outside of pathology. There can be secondary gain issues, lawsuits, and psychometric properties have been shown to adversely impact your pain response. So I think we need a better modality. I think we need a better diagnostic tool to help us figure out discogenic pain. I think discogram is a thing of the past. I think it's antiquated. And I'll stop there. Thank you.
So I am a non-surgeon. I'm a physiatrist here at Harborview. Which of these are you treating? And therefore, is your treatment the psychosocial variables and the treatment of chronic? Are you really treating the disc? So that's last on my list. We're going to talk about a couple things. I'm going to go through some basic numbers of sort of what we are doing. You also have to understand your patient care, what we're doing with our patients. What are their belief systems? What are they talk about the issue of what we are actually treating. What is it we think we're doing when we treat patients with chronic low back pain? What is the idea? Unmet expectations are very unpleasant. We'll go through some data and look at our treatments and do our treatments for chronic low back pain really work? And if they do work, why do they work? And fundamentally, we're trying to say a couple of different things. One, a bit anathema. You also have to identify potential of what you can do that you're going to run into. So depression, in treating the disc, getting these patients with chronic low back pain, we're largely treating the wrong catastrophizing. These come up over and over and over again. And you empowering the patient is the if they exist because they predict a poor outcome. Personality disorders. So we can start with the idea we can put all sorts of things into a spine. We can put needles and cages. Personally, I think we should be screening our patients in some method. And we do put lots of things in there. We're putting maybe this is a very good history. Maybe this is a very good conversation with your patient. I don't know that one tool has been proven to be the ultimate sort of 2005, just showing the rate of lumbar fusions going up over. There's several that can be helpful. The DRAM can be helpful. A Zung, which is a depression scale, can be helpful. Procedures, the same thing. So over a decade, which can be helpful. The rate of interventional procedures on the Medicare population, the fear avoidance belief questionnaires can be helpful. Going through curious, Mike Dobbs put a paper out in 2011 discussing the use of these in the spine rate at which we intervene on spines. And frankly, if this isn't part of your practice, this isn't what you do. If you look at the math on this, from 1992 to 2002, Medicare spent more. Maybe someone spending on Medicare for Medicare in inpatient spine surgery more than doubled. Who's going to do this? And the payment for lumbar fusion alone went from $75 million to $482 million over 6 years. Realistically, to really help our patients, we have to give them the right treatment. At the same time, the rate of lumbar fusion with the right reason, the percentage of cost spent, the percent of money spent on lumbar fusion rose from 14% to 47% of all the spending. I tell the residents this every day. This came 100 years ago from William Osler. You look at this idea that we hurt, and therefore we can figure out where we hurt from and get rid of what hurts. Has the disease and which disease in the low back has. Our ability to really discriminate where the pain is from is not adequately represented in our cortex. We can't distinguish different structures in our back. We know our back hurts. Looking at the data, psychosocial variables are clearly associated with outcomes. Is it disc? Is it muscle? Is it bone? And they are much more. We don't tell. We can't tell. We don't have the sensory ability. Non-operative care should really be directed towards empowering the patient and overcoming barriers. When you really boil it down, pain is one part nociception and 3 parts surgery for discogenic pain is largely treating the wrong but the problems start to come. And frankly, I think what we do to our patients with chronic low back pain, also know that people with chronic low back pain don't just help them believe that they have lots of other problems. Things happen. This is the experience of pain. So there are distinct changes in the peripheral central nervous system. This is not just a disease of the low back. You know that the distinct changes in mood that gets you in trouble is what you know for sure that there are problems with physical conditioning and a lot of problems with social roles. What happens to people who have pain, become disabled, they can't do what they want to do, think they should. Things change. Just one example of this, there's tons of this in the literature on the biologic changes that go along with chronic pain. This is from a video at Carey in Chicago, who does a lot of work with functional MRI and pain. And this came out in 2004. What they found is there is discrete atrophy in a distinct part of the neocortex associated with chronic low back pain. And they found out 5 to 11% less neocortical gray matter in the dorsolateral prefrontal cortex. This is a pattern very distinct in chronic pain patients, and it's equal to the amount of gray matter one might lose in 10 to 20 years of aging just by having chronic pain. So you go back to the discography, does surgery work, the whole thing, you take the disc out, you're not really changing the brain. The other thing you have to realize is we keep talking about pain, we're treating pain, but pain and disability are different things. Pain and suffering are different things. We'll talk about that later too. But pain and disability are different things. And disability is not necessarily due to the pain that people experience. There are several modeling studies in this, psychological modeling studies of why people are disabled from their chronic low back pain. And it's very curious because when you look at them, pain comes out to account for about 10 to 24% of the variance in terms of low back pain related disability. Whereas the data on fear avoidance and catastrophizing, two distinct sort of psychological characteristics, account for more than a third of the variance in disability. So it isn't necessarily that even though they had pain, they're disabled because of their pain. So this brings us to the idea of looking at what we do and does it work, and if so, why does it really work? So what are some of the things that really predict patients, the response of patients to treatment? So we treat patients with chronic low back pain. What things can we find that predict whether or not they're really going to get better? This has been pretty well studied. Treat et al. In 2000 had a survey of 102 patients who had surgery for chronic low back pain. Most of these had fusion done. They didn't actually say what the rest had done, which is sort of curious. They did pretty extensive pre-op psychological screening, and post-op they followed pain and other outcomes at 6 and 12 months. And what they found was that when you had preoperative levels of elevated depression and anxiety or somatic anxiety, patients have failed to report improved pain, they failed to report improved outcome or function, and they failed to report improved rates of return to work. Of all the sort of scales they looked at, they found that the DRAM gave them the best sort of correlation with outcomes. This is the distress and risk assessment method, which is a combination of two other scales, the ZUNG and the MSPQ. So another study came out last year, Shoshana et al. in Journal of Surgical Spine. They did a study looking at patients who had discectomy, so 67 patients who had a discectomy for a one-level disc herniation. And this is a patient population we usually think of as doing well with spine surgery, right? Patients with a discectomy tend to do fairly well. What they looked at were post-op pain and function and pre-op depression and somatization rates and tried to see how this might correlate with their outcomes. Again, they used the ZUNG and the MSPQ, which really is the DRAM that they were using. What they found is sort of interesting in that this idea of we're treating pain. So in the whole group, people actually got better. Pain got better. So VAS pain for leg and back pain got better. ODI, physical function, people were better. This group was better as a group, which is what we would expect for this particular surgery. However, when you had high levels of preoperative depression and somatic anxiety, there wasn't really a change in the rates at which pain was relieved. But these patients had a decreased likelihood of improvements in function and quality of life. So their pain got better, but their life didn't really get better. So again, maybe pain is not the thing to be focusing on. So in the aggregate, we look at these numbers and say, how helpful is this? So we have this idea that fusion may work for some of these people. Maybe it's equivalent to some non-operative care. So even non-operative side, are we doing this well? So is this good? Are these good outcomes we get? And all these studies, the ODI is decreased about 12 to 15-ish, somewhere in there. Pain is usually decreased about 2 out of 10 for our fusion studies. What do people really want? So is this good? Is it good to go from a 5 to a 3 or a 6 to a 4? Well, Karaji and Cheng did an interesting survey in 2010. They surveyed patients who are going to undergo lumbar fusion for a variety of reasons, including spondylolisthesis, said, what do you want from this surgery? And this is what patients wanted. They wanted a pain decrease of at least 3 out of 10. They wanted their ODI to decrease at least 20. They wanted no more use of opioids, and they wanted to go back to their activities. They wanted to go back to their physical life. You may look at that and say, well, we didn't meet that. Right? The studies don't meet that. So can anything meet this? Is this reasonable? Maybe our patients have unreasonable expectations of what we can do. I'll go back to the study Mike just mentioned a few minutes ago, the Karaji study from 2006, looking at patients with spondylolisthesis versus discogenic low back pain. So I have to be fair. So we do a lot of exercise things. We talked about exercise in the setting of the studies. How helpful is exercise? We've been doing exercise for low back pain for a very long time. These are pictures from the 1800s of how to keep a healthy back. That's like a little Bosu ball the kid's sitting on, just a progenitor of that. Over the last 60 years, we've had lots of sort of theories of low back exercises. We had the Williams flexion exercises, we had the McKenzie extension sort of things, we had this big neutral spine thing back in the 90s. Now it's sort of core stability, which has infiltrated every single gym on the planet, is at playgrounds, is at fishing holes, is in the NFL training camps. It is everywhere, right? So we have the same question, though. Does this work? And if it does work, why? And Stu Weinstein, my partner and I, John Rapeltis, a PT at Olympic Physical Therapy, did a systematic review of this several years ago. And there actually is evidence that when you compare it to sort of nothing else, core stability programs do sort of work. However, there's very good evidence that when you compare them to other active treatment programs for patients with chronic low back pain, they are no better whatsoever. They are the same. There's nothing uniquely special about core stability versus other active exercise programs. This has been found in multiple other systematic reviews as well. Here's one from 2010. Same basic conclusion. Stabilization exercises are more effective than a minimal intervention, but are not more effective than other physical therapy interventions for treating chronic low back pain. Right? There's nothing uniquely special about it. So in my current world, I run into this phenomenon quite a lot. It says my physical therapist says this is the worst possible position you can lie in, but maybe we're not quite treating the right thing. So how helpful is exercise? We'll go back to this issue. So we have some of the same data for exercise that we have for surgery. So Vessels et al. Put out a study in 2006, a systematic review on changes in treatment variables that predict outcomes with non-operative care, very similar to our surgical studies. They were looking at studies on exercise, behavioral treatment, and multimodal care. And what they found is sort of similar, that when you have improvement in coping mechanisms and pain reduction, you get decreased disability and increase in return to work. So people can cope better and function better, things go better. Physical performance factors were not linked to improvement. So that means you tried to exercise them to make them stronger. They got better, but it didn't really seem to matter whether you got them stronger or not. This has been found in several other studies. Felix Steiger, who works with a group in Zurich, put out this study in 2012, a systematic review on a correlation of physical response to exercise and outcomes in treating chronic low back pain. So to break down the English a bit, what they looked at were studies on exercise that reported a clinical outcome, so did patients get better, but also a physiologic outcome. So we gave them back extension exercises, and then we measured their back extension strength. We gave them cardiovascular exercises, we measured their cardiovascular performance at the end of the study. And what they wanted to see was, did people get better with exercise, and did it correlate to whether or not they actually achieved the physiologic benefit of the treatment that they were given. They had 16 studies they found with 1,500 patients in them, and they found very little correlation between changes in pain and function and changes in physical performance. So in these studies, people largely got better, but they didn't really physically perform any better. So they treated them thinking their back extensors were weaker. They did the back extensors exercises. The patients got better, but their back extensors didn't get any stronger. It didn't seem to matter, which is very curious. What they felt is the findings do not support the notion that the treatment effects of exercise therapy in chronic low back pain are directly attributable to changes in the musculoskeletal system. So maybe it isn't treating the body so much that helps. Oops. This raises a fundamental question. So we do exercise and we have this issue. Is it really, really, really about motor control, about what we can do with our bodies? Or is it about locus of control, what patients can do with themselves? What are we trying to do through exercise? How do we actually help our patients? Try and get some nuts and bolts. In general, I'm a rehab guy. This is what I do all day long. Identify and address barriers to improvement. What is going on? Establish reasonable goals. What can people do? What's achievable here? What's reasonable? Find a treatment program that resonates with the needs of the patient, and empower the patient. And try and get them to a goal somewhere that is fulfilling for them. More importantly, how do we do this from our perspective today? So before operating, on this issue of psychological variables, what do we do with this? Well, several things. Before we operate, what are the goals of treatment? Are you treating pain? Are you trying to get pain better? Are you treating suffering? Are you treating disability? Are you treating depression? Are you treating distress? Which of these are you treating? And therefore, is your treatment the right thing to do? Are you really treating the disc? That's last on my list, because it's last on the list of most things, frankly. You also have to understand your patient. What are their belief systems? What are they looking for? What do they think is really going to help? What do they buy into? What do they not buy into? What do they expect? Unmet expectations are very unpleasant for most people. What are their real goals in terms of treatment? And what barriers exist for them? You also have to identify potential problems that you're going to run into. So depression, anxiety, somatization, fear, catastrophizing. These come up over and over and over again. And you should find them if they exist because they predict a poor outcome. Personality disorder is the other one. So personally, I think we should be screening our patients in some method. You know, maybe this is a very good history. Maybe it's a very good conversation with your patient. I don't know that one tool has been proven to be the ultimate sort of do this and you're good sort of thing. I don't think we have that. There are several that can be helpful. The DRAM can be helpful. A Zung, which is a depression scale, can be helpful. There's a Beck Depression Inventory, which can be helpful. These are all fairly short, not ridiculous questionnaires. There's a Fear Avoidance Belief Questionnaire, which can be helpful. If you're curious, Mike Dobbs put a nice paper out in 2011 discussing the use of these in the spine literature. And frankly, if this isn't part of your practice, this isn't what you do, you're not going to do this, find somebody to work with who does do this. Maybe someone like me, a non-operative person, maybe a psychologist, find somebody who's going to do this to help you sort through your patients. Realistically, to really help our patients, we have to give them the right treatment to the right patient for the right reason, and our outcomes will be better if we do that. And I think of this pretty much every day. I tell the residents this every day. This came 100 years ago from William Osler at Hopkins. It's much more important to know which patient has the disease and which disease the patient has. If you start that way, you will most likely find the problems. So to conclude, looking at the data, psychosocial variables are clearly associated with outcomes. And they are much more important than the disc. Non-operative care should really be directed towards empowering the patient and overcoming barriers to improvement. That's what it should be. Surgery for discogenic pain is largely treating the wrong problem. And frankly, I think what we do to our patients with chronic low back pain is less important than what we help them believe that they can do for themselves. That should be our goal. As you go through the afternoon, you can think of the words of Mark Twain. It ain't what you know that it ain't what you don't know that gets you in trouble. It's what you know for sure that just ain't so. I am done. Thank you.